Okay.
Yes, thank you.
Okay. Thanks for introduction. Good morning, everyone. In China, the outbreak of COVID-19 began in late January this year. Our hospital was the earlier designated hospital specialized in the treatment of COVID-19 patients. And from that time, all the medical staff were reassigned to new positions. But during that period, I came to the fever clinic. Today, I would like to share with you some ideas and experiences in my work. First of all, understand the main clinical characteristics of COVID-19 patients in China. In the context of pandemic, we should keep alert to patients with these symptoms. Fever is one of the common symptoms. Among the patients, 43.8 had fever, and nearly half of them had a moderate fever, and the other 40.8% had a low-grade fever. The cough is the most common symptom, and 67.8% of the patients had cough. The other two common symptoms were sputum production and fatigue, and each of the rate of occurrence was more than 30%. Beginning from late January, the patients with fever, cough, and the other special symptoms were initially classified as the suspicious patients, all of whom had accepted further examination. Other big periods in China is that the management outside the hospital was turned to the respective communities. The patients with fever and other suspicious symptoms would report to the communities actively, and the community commissioners are responsible for arranging them to the designated hospital for treatment. And it is not recommended to go to hospital by themselves. The advantage of this law is that you can have detailed information about the source of each infection. In the fever clinic, masks, masks, not necessarily surgical masks, were provided for all patients, including the accompanying procedure, because masks can reduce the spread of droplets and prevent the cross-infection. The procedure of fever clinic should be clear, and the dedicated personnel are arranged for triage. All patients need to carry out various nucleic acid detection, blood routine test, and Lancet examination. In outbreak period, extensive examination is very important. Once the condition is confirmed, such as confirmed or highly suspected cases, the patient should be arranged to isolation center or to be hospitalized as soon as possible. If the initial diagnosis is negative, the patient should be tested twice or more times, and the lung CT should be checked after 3 to 5 days. If the nucleic acid test is still negative, it is also recommended to isolate themselves at home for at least a few days until the symptoms disappear. During the isolation time, close contact with their families should be avoided. For those severe and critical severe patients, we need to identify them in time, arrange priority treatment and hospitalization as soon as possible, or even admission to ICU. In fever clinic, we tried to reduce the waiting time of all patients in the hospital. When the number of patients surged in early February, fever outpatient doctors were added accordingly. But at the same time, is very important too. We should also try to reduce the continuous working time of medical staff to reduce our risks of infection. However, at the beginning, because of the serious shortage of healthcare workers and not fully understanding of the serious consequences of this virus infections, the continuous working time was up to 12 hours. With more healthcare workers joined the assistant team, the continuous working time was reduced to 6 hours and finally 4 hours. Therefore, we emphasize that suspicious patients with the above symptoms need to see a doctor in time. The first important step is to do the nucleic acid test and the antibody test of COVID-19, both of which are highly effective diagnostic measures. Second important step is isolation. Once the diagnosis is confirmed, the isolation will be carried out immediately. But the previous experience in China shows that the isolation of patients at home is not reliable, which could cause family or community transmission. Later, special isolation places have been set up, including the shelter hospital. Now it seems that it is very effective to isolate the confirmed or highly suspected patients and equipped with professional medical staff for management, which can quickly cut off the source of infection. For general people, it is also very important to stay at home and stop socializing to reduce the risk of infection. Due to the limited resources of hospital beds, it's vital to implement the treatment in the fever clinic. For those patients waiting for beds in fever clinic, oxygen therapy will strive for more survival opportunities for them. We also need to find out which people need oxygen therapy in time. If there is no limitation for oxygen therapy device, oxygen therapy can be started for patients with blood oxygen saturation less than 93% in China. For the awaiting patients, if the condition is unstable or serious, observation rooms are set up, which are managed by dedicated doctors and nurses. It is key to identify those patients with rapid progress in time, but it's very difficult sometimes. When the nasopulmonary oxygen therapy is not enough to reduce and improve the symptoms, it is recommended to proactively give respiratory support treatment, from nasal cannula to high flow oxygen therapy. And the timing of using the ventilator is suggested to be earlier than that for general respiratory failure patients. Regarding the antiviral treatment, Abidor intravenous ribavirin, etc. are suggested to be taken based on China practices. It should be noted that these treatments are all empirical treatments at the early stage of the epidemic. And it is not recommended to use more than 3 antiviral drugs at the same time. And the course of the treatment should not exceed 10 days. In China, about 20% of patients with COVID-19 would progress to severe and critical severe patients. For those patients with respiratory failure requiring mechanical ventilation, shock, or other organ failure, they need to be admitted to ICU for monitoring and treatment. During the outbreak period, more medical staff, beds, and ICU wards are needed. Wuhan, located in the center of China, was the epicenter of the COVID-19 pandemic, with the strong support from the whole country. The pandemic situation has been gradually contained, and the city is reopened and restarted today after 76 days lockdown. We also hope that global pandemic will be.
Hello, good morning.
Good morning.
Yes.
Yeah, good morning. My name is Dr. Noel Bakley. I'm a chest physician from Salford. Can I ask you a question about the treatment you have used? You did talk about multiple regimens in terms of treating COVID-19. Did you find any difference in the treatment you used compared to the course of the disease? Have you tried to apply certain treatments at certain phase and other treatments at a later phase? Or did you apply the treatment based on the clinical presentation or any other factors?
Our own guideline and classified this disease into the 4 types. It's classified into mild one, the moderate, the critical, and the severe and the critical. So, to the different types of conditions, the medical medicine is also different, and also to the different phase of the disease, and also different methods. And as well, in the early phase of the disease, the support supply also, like the oxygen therapy and the other food therapy, is very important. And also the to the mild supply, to a mild type of the patients, the quarantine or isolation at home is best therapy. If the patient have the obvious symptoms, such as a cough, such as a fever, such as the disease, the chest pain, and they can enter the designated hospital throughout the fever clinic. Yeah, and in the hospital, we can also use some of the therapy, the medicines, and the traditional Chinese medical therapy, and the medicines such as the antiviral therapy is very important, such as the epidural, such as the ribavirin, and others. Also, the alpha interferon is also can be used in the early phase. But I can for special pay attention to the glucocorticoid is not necessary in the early phase. It's very important, and because the non-proper use of the glucocorticoid may accelerate the conditions of the disease. And besides that, also we can have some oxygen therapy, such as the mask or the lethal use. And if the patient happen to the oxymer, we can use the ventilator. But the elevator can be not used easily if necessary. And besides that, we also have some traditional Chinese medical medicines. And
we have heard about all these.
Morning, everyone. 请允许我用中文来解析这个防控工作的相关工作。我们请我们的王博士来辅助我，来完成这个我们之间的这个沟通。那么我们医院是在2019年12月底接诊了第一例的这个疑似患者之后，越来越多类似症状的患者涌到我们医院，那么主要集中在我们的急诊和呼吸科。此外，其他的部门也收了部分症状不典型的患者。面对越来越多的患者，我们医务人员承受了很大的压力。The first case of coronavirus in our hospital was established in the end of December last year. Shortly after that, more and more patients with similar symptoms poured into a hospital, most of which is centered in ER and respiratory department. The situation overwhelmed the medical staff of ER and the respiratory department. Besides, typical patients also messed the doctors up. All medical staff were under great stress, facing torrents of patients flooding into hospital. 那么这是一个呼吸道系统的一个疾病，后来发现非常容易在人际中进行传播。那么我们流行病学的专家报道，也就是一个患者他是可以感染2到3个健康人，那么感染的病例可以在2到3天内这个纷纷的播散。This is a kind of respiratory-borne illness, and it turns out to spread easily from person to person, with high degree of mobility. Epidemiologists have reported that the virus can transfer from one patient to 2 to 3 healthy persons and infect them. Cases can double in 2 to 5 days. PPT 要调一下。没有，就是开始。那么这些都为医院感染控制带来了很大的一个难度。为了应付这些挑战，我们采取了一系列的防控措施。我们接下来分享的措施，我们认为还是非常有效果的。Those all brought many difficulties for the prevention and control of nosocomial infection. To cope with that, we have taken a bundle of preventions and control measures, and we thought the following measures were really counts. 那么最重要的一点就是政府采取了很积极的一个应对的措施。疫情发生以后，武汉市是立即就封城，那么所有的居民是待在自己的家中，商场、学校、体育馆等等公共的场所均被关闭。那么这些强制性的措施也阻断了新冠状病毒在人群中的一个传播，延缓了病例上升和扩展的速度。First and foremost, in the fight against the coronavirus, the government had taken positive measures. Wuhan had been locked down immediately after the outbreak of this coronavirus, and all residents had to stay at home. Shopping malls, grocery stores, schools, and other places where people may gather together were all shut down. It's a mandatory order that could block the virus transmission among crowds and stop the case numbers from increasing. 那么此外，在短时间内，武汉市建立了方舱和隔离点，用于轻症患者的就诊和隔离，那么减轻了综合医院的这个压力。那么在10天以内的时间，建立了2个这个传染病的医院，将大型综合医院改造成为收治新型冠状病毒肺炎的定点医院。那么举全国之力，调集了几万名的医务人员来增援武汉。那么这还给武汉调拨了大量的防护用品和生活的物资。这些举措都避免了综合医院的医疗资源的挤兑和崩溃。Many functional shelters and quarantine points had been constructed in a very short time. Mild infected patients could get medical support and be isolated there. That reduced the suppression of general hospitals. Meanwhile, 2 contagious disease hospitals were built in 10 days. Many general hospitals were remodeled to coronavirus designated hospital according to isolation requirement for contagious disease. Once, 然后thousands of medical personnel from all parts of the country were assembled in Wuhan to provide medical support. A large number of A large number of PPEs, medicines, and other important materials are provided to people in Wuhan. All those measures mentioned above relieved the pressure of general hospital greatly and prevented hospitals from collapse. 那么我们医院也实施了一系列的防控措施。首先，我们是设置了专门的隔离病区来收治确诊和疑似的患者。那么隔离病区的布局和工作流程均满足我们国家的均符合我们国家的隔离消毒技术相关的一些要求和规范。隔离病区分为3区2个通道，以及增设了2个缓冲区。那么在清洁区、潜在污染区和污染区之间，3区之间还有加上了2个缓冲区。那么医务人员和患者的通道是分开的，其他无关人员是不能接近隔离病区的。In our hospital, a number of prevention and control measures were taken. First of all, coronavirus confirmed patients and suspected patients were resettled in isolation departments. Observing strict isolation strategies, the isolation departments were remodeled according to the isolation requirements for contagious disease. The workflow met the relevant requirement of the hospital isolation technical regulations. The isolation departments were separated into 3 quarters, namely clean area, semi-contamination area, and contamination area. 2 buffer rooms were set up to separate the 3 areas. 那么隔离病区不同的区域有特定的一个防护的标准。那么隔离病区每个工作人员在进出病区的时候都必须严格按照要求穿脱防护用品。那么此外，缓冲区有专门的感染防控技术人员进行督导，一方面对医护人员穿脱防护用品进行督导，另一方面对防止污染区的物品回流进入的清洁区进行一个监督。Professional staff and patients had a different separate passage in case of cross infection. Other people unrelated are strictly limited access to isolation wards. Specific guards for different areas were essential for efficient isolation. Every healthcare worker was strictly requested to wear and take off isolation garments properly when they entered and left the department. Infection prevention and control technicians were assigned to prevent items from contaminated area being brought into clean areas, and to supervise the medical personnel on putting on and removing protective equipment so as to prevent contamination. 那么适宜的个人防护用品对于这个院感的防控十分的重要。那么疫情初期的时候，我们制定了适合于我们医院的一个穿脱的防护用品的一些流程。那么隔离病区医护人员要戴这个医用的防护口罩、防护服、一次性的医用帽、一次性的手套、防护眼镜和一次性的防水靴套。此外，医务人员在给患者插管、做手术操作一些高风险操作的时候，需要加戴一些正压的头套。Adequate personal protective equipment is essential for preventing nosocomial infection. We made guidance on wearing and removing personal protective equipment. At first, every staff working in isolation wards should wear medical protective masks, medical protective garments, disposable surgical cap, disposable gloves, goggles, disposable waterproof boots. Particularly, doctors and nurses should wear positive pressure ventilation protective hood during the performance of intubation operation. 那么所有的这个隔离病区的医务人员在上岗之前都需要经过防护用品穿脱的培训。此外，一线的工作人员需要进行每日的健康的监测，鼓励他们尽量居住在相对独立的一个隔离区域。如果工作人员有新冠相关的一些症状，而立马对其进行隔离，并完善其相关的检查。那么一线工作人员在工作2到4周以后，会进行2周的一个轮休，以保证其这个身体的状况的保持一个良好的健康的状况。Before working in the isolation ward,
every professional staff had taken the training of how to put on and remove personal protective equipment. Health monitoring and health status record should be conducted for all frontline staff. Medical staffs were encouraged to live in an isolation accommodation. If a staff had any relative symptoms such as fever, they would be isolated immediately and screened with other tests. After working in isolation ward for 2 to 4 weeks, professional staff would have 2 weeks quarantine to get enough rest between shifts and assure their good health condition.
根据各种规范和指南，我们也出台了自己这个隔离病区的清洁消毒的要求，包括环境物表、空气、患者的排泄物、血液、体液、分泌物等等清洁消毒的一些要求。那么所有病区每天要进行清洁消毒2到3次，整个消毒过程要保证足够的消毒时间和适宜的这个消毒剂的一些浓度。
According to guidelines and regulations, we have published the disinfection procedure for coronavirus isolation department, including disinfection of environment, objective surface, air, fecal matter, and spills of patients' blood and fluids. All isolation wards were carried out disinfection 2 or 3 times a day, and repeated the procedure at any time in case of contamination. Make sure that disinfection time is enough and the concentration of chemical disinfectant is suitable.
在隔离病区当中的疑似患者要单间隔离，那么确诊患者可以放置在一个房间，床间距至少是1.2米。那么每个病房都配置有足够的设施，包括卫生间等等。患者活动要局限在病房以内，是禁止探视和陪护的，减少不必要的一些诊疗活动。那么鼓励患者通过电子设备与亲朋好友进行联系，对患者进行咳嗽礼仪、戴口罩、戴外科口罩、舍卫生、居家隔离等进行一个健康的宣教。
Suspected patients were isolated in separated single rooms. Coronavirus confirmed patients can be arranged in the same room with bed spacing of no less than 1.2 meters. Each room should be equipped with facilities such as private bathroom, and the patient's activities were confirmed to the isolation ward. Family visits were forbidden and nursing shall be declined. Patients are encouraged to communicate with their family members and friends by electronic devices. To prevent further spread of coronavirus, patients were educated and instructed on how to wear surgical masks, proper hand washing, take the COVID-equipped medical observation, and home quarantine.
对隔离病区的工作人员的行为要进行一个督导，要求做好守卫生，要避免高风险行为的一些发生。
All frontline staff were supervised by infection prevention and control technicians to comply with hand hygiene and to avoid high-risk behaviors.
那么上述提到的一些防控措施，有效保护了我们的医务人员，也阻止了医院感染的发生。我们的经验表明，通过积极有效和严格的一些措施，隔离病区的医务人员是可以得到有效的这个保护。
All the measures mentioned above have effectively prevented our medical staff from coronavirus. Our experience indicated that healthcare workers on the isolation ward could be effectively protected from contracting by taking efficient and strictly observed protective measures.
好，发言就这些，谢谢。
Thank you.
Is every patient who came in contact with the medical profession got tested, or only those who had symptoms?
Nearly all the patients who came to our outpatient will have a series of tests. If the patient has the symptoms of fever, cough, diarrhea, fatigue, or something like which think they are suspicious patients, so we will give them the test. And also during the epidemic time, in the last 2 months, the majority of patients with the other diseases, they do not really choose to come to the hospital. They will stay at home. So only the patient who have some troubles or some symptoms, they will come to our hospital. So actually, I think the answer should be nearly all the patients who came to the outpatient will receive the test.
Good to see everybody. I come from Wuhan. My main topic is about the normal patient about COVID-19. The severe and critical patient will talked by Dr. Wang. In my hospital, the main patient is the symptom is about fever and a dry cough or progressive dyspnea. Some patient will become perhaps below the ARDS, and the other symptoms include diarrhea, fatigue, or the chest tightness. And most of the people about the age above the 90 years old and the main patient are more vulnerable. And the old age, obesity, and the patient have the chronic disease might be associated with include mortality. As we know, we will very important thing is clinical history. As Professor Penn, he tells us that the second and the third week from the illness onset is a critical period. It's about 15 to 20% of all the people at this period will become and increasing into the severe or critical patient. And the third laboratory test in most patients is white blood cell will decrease and the fourth size will decrease. The other is about LDH, D-dimer,
antiviral ointment as well as the antiviral
inflammatory factors. Example,
those who are not speaking, can you put yourself on
the
mute?
IL-6.
2 weeks, 5 times a day.
Can we have
Don't touch me.
Can you switch off your mic, please? Okay.
And okay.
Yeah.
Laboratory test and the chest radiological imaging should be close emotioned, and we should get the nose or throat swab, sputum, no respiratory tract or blood or stool is positive for SARS-CoV-2. And the chest radiology, and this is a common case from January 19th to January 31st. First is the ground glass mobility. It become the area is more, and after our treating, it's most of them is observed. And the third patient is a man. From this patient, at the first day we can see a GGO at the red lobe, and the third day the area is increasing. We give them the antivirus and antibiotics and give some low dose of corticosteroid for about 5 days, and as well as supportive treatment. And after that, the 15 days, most of the GGO is disappeared. And the third one is a severe case. It's a female. It's about 76 years old. This patient, and at first, it's just as both of the low lab is at the GGO, and after about 2 weeks, its patient, its areal is continue to increase, and so we give him the high flow oxygen. And the CT exam, we should, as we check, the time for CT re-examination is about 5 or 6 times. First time is about the number is the third or 5 days. 5 days, and the third exam is about at the 7th or 10 days, and if the third or fourth examination depends on the patient's condition. And we also give the patient some bronchoscopy. As we found from the bronchoscopy, we can see nothing in the trachea or the bronchs. It's very, as we say, it's very dry. As our clinical classification, the mild case is about without the pneumonia. The common case is about a fever, respiratory symptom, and in our radiologic map is have pneumonia. But as we know, it's very important that special focus on the second and the third week is about 15 to 20% of patients will progress to severe case or critical case during this period. And the severe case is about respiratory distress, especially his respiratory rate is all about above the 30. This is, I think, the respiratory rate is very easy and very important parameter. And the oxygen index is about below 300, and about 50 programs in chest radiologic imaging within 24 or 48 hours. And the critical ill cases is all about respiratory failure, is need marginal ventilation, and or they have shock or multiple organ fault. So this patient must be transferred to ICU. And at this period, we should do with the different technology is about the unknown variants of pneumonia or bacterial pneumonia and the other non-infectious disease. So it's very important to us. But it's very dangerous to us that at this period, we don't find the other variants of pneumonia. It's very strange to us. The main treatment plans about the patient, we ask the patient rest in bed, monitor vital signs, supportive treatment, and maintain internal homeostasis. And we should check the monitor blood routine, organ function, and inflammatory factor, blood gas analyze, and so on. And we check something within 3 to 6 days for mild case, and 2 or 3 days for several cases. And the very important, the critical case, we must check again in 1 or 2 days. And oxygen treat is very necessary. As we know, antiviral treatment is about several drugs or the other treatment. But to my opinion, no one is a winner. To my opinion, there is the biggest or the best drug to treat with the COVID-19. And the antibiological threat, we should avoid planned or improper use these drugs. Treatment for several critical illness. The main is relieve symptoms, prevent and treat complications, and treat comorbidities, prevent secondary infections, and timely multiple organ support therapy. And especially we should, I think it's very important to this parameter. It's about the continuous decrease lymphocyte count, and especially the marked no count of the B lymphocyte. It's about the other there especially decreased number of CD40 cell and CD8 T cell, and increasing and the marked increased inflammatory factors, especially that IL-6 or CRP, or the other parameters. We say again, the respiratory rate is about 30. I think it's very easy to observe, and it is very important. It is very important to the patient. Most patients, most of the severe or the critical patient, the respiratory rate is very fast and more fast. Tell us that the patient is will become the better, is the best, worse. And I think cortisol treat is very important in the COVID-19. It's indication about rapid progress in chest radiologic imaging or is below the 93%, at rest without oxygen. The other one is respiratory distress is about above 30, or the oxygen rate is below the 300. There is a clinical case. This is a 39 male. He is with fever and cough is about 6 days. From the 26th January, he is, has a diabetes. From his chest imaging, it is shown pneumonia. His respiratory tell us that at the first 3 days, his respiratory rate is more and more higher. And after our treat, his respiratory rate is become lower. And it's about 1 month, his respiratory rate is become normal. And his white blood cell and lymphocyte so we can see that at the first 3 or 5 days, his lymphocyte is become lower, and after our treat, their lymphocyte is become above the 1 set. The other is LDH. It also tells us that if LDH is very high, some of them is tell us the patient could become the severe or critical. After our treatment, the patient LDH is become lower. And the other from the product gas analysis, we choose the oxygen is become low at the first 3 days. After our give some oxygen treatment, the patient's oxygen is become higher. From its imagine we can see at the first, the patient, the area of inflect is very located, and after 3 days, the area of his is become too low, and his breath is very is too fast. It's about 10 days. The area is become, and after our treat, the area is become decreased. It tells us give some treatment. The O is give some prednisona. At the first 2 days, we give it 40 and Q 12 hours. After 2 days, his respiratory failure is become higher. So we change our sauna at Q8 hours. After 2 days, his symptom is become better. So we decrease the dose of the sauna, and it become it treated at the from the 26th January 26th to February 8th, and the other treat is about ritonavir is from the first day to it's about 15 days, and the other is about antibiotics to treat, but it's just only 3 days. But I think the other important treatment is about high frequency nasal oxygen. It's from the 3rd days to it's about continue. It's about 2 weeks. So in this patient, our experience is about timely judgment, treat of steroids, and the other important treatment is persistent oxygen treat and high frequency nasal treat when necessary, and the other have the other therapy. So this is the magic of our doing the bronchoscopy, and this is our college. They are our heroes, and this is the team. They are the great team. So that's all for today. Thank you.
Attending physician in ICU from the Wuhan Central Hospital. I'm honored to present this presentation to you. Next, I will share our experience about the treatment of critically ill patients with COVID-19 with you. In December 2019, a novel coronavirus disease caused by SARS-CoV-2 infection broke out in Wuhan and spread rapidly throughout China. As of March 31, 2020, the World Health Organization reported more than 1 million COVID-19 cases have been confirmed in at least 200 countries, and more than 60,000 people died from the COVID-19. This picture shows the epidemiology of COVID-19 in our hospital. With the outbreak of COVID-19, the Wuhan municipal government has issued a series of policies, including the closure of the South China seafood market, lockdown of Wuhan city, the establishment of designated hospitals, temporary cabin hospitals, and the construction of 2 hospitals which are specific infectious hospitals. The number of patients reached a peak at the end of January and then gradually decreased. From this chart, we can also see that most patients died in February. A couple of factors probably caused the high mortality among the COVID-19 patients in Wuhan at early stage include the sudden emergency of a large number of patients. Most hospitals here have problems with oxygen supply. Most of wards are not suitable for infectious disease. and the lack of medical personnel and materials. Epidemiological study in China showed that the overall mortality rate of COVID-19 patients was 2.3, and the mortality rate of critically ill patients was 49%, even as high as 60% in the early stage in Wuhan. This is a single-centered retrospective observational study. 52 critically ill adult patients with SARS-CoV-2 pneumonia admitted to the intensive care unit were included. From this chart, we can see that the mortality of critically ill patients with COVID-19 is 61.5%, and the median duration from the ICU admission to death was 7 days in the non-survivors. An analysis of 109 COVID-19 patients from our hospital in early stage showed that mortality rate of COVID-19.
Yeah, I'm off today. Yeah.
It's of on admission, the LDS on admission was nearly 50%.
Sorry?
Therefore, the treatment of critically ill COVID-19
Can I
patients.
remind you who are not, asking this? Can you just silence
Which one?
your microphone?
Is there any problem?
Yeah. No, it's actually on TV now. But it's not ventilated. It's not on ventilation. But it was moved to ICU. I think yesterday or something.
Nasim Saidi, please turn your microphone off. Nasim Saidi, please turn your microphone off.
Okay.
And for anyone else who's got their microphone on, please turn it off so that our team in China can do the presentation.
Okay, I will go on. So the treatment of critically ill COVID-19 patients is of great challenge. How to reduce the mortality rate of critically ill patients with COVID-19? I will share a case report with critically ill patients with you. 42-year-old male was admitted to our hospital on January 21, 2020. He had the initial symptom of fever. The maximum temperature was 38.8 centigrade, with cough and fatigue. No dyspnea, no chest pain, no abdominal pain, and unconsciousness disorder. We could see raised leukocytes and decreased lymphocytes and platelets. The renal function, the liver function, and the coagulation seemed normal on the first day admitted to hospital. On January the 22nd, the chest CT showed a few patches, but on the January the 13th, 8 days later, the chest CT re-examination revealed progression of the lesion, and a throat swab sample confirmed that the patient had a COVID-19. Given the serious shortness of breath and the deleterious hypoxemia, he was transferred to ICU on February the 4th and was given invasive ventilation on February the 8th. The medication from day 1 to day 12 included antiviral therapy, anti-inflammatory and immune modulating drugs, antibiotics, and also include anticoagulation therapy. Even after intubation, the patient was under progressive deterioration. He was diagnosed with AKI and severe ARDS. We used the non-protective ventilatory strategy, prone position ventilation, and deep sedation, but the hypoxemia was not resolved very well. So on the day of the intubation, we initiated the VV ECMO on the patient. And after a period of 6 days usage, we assessed the patient condition and weaned the ECMO from the patient. But the patient was not stable. The oxygenation deteriorated again. We had to initiate VV ECMO once again on February the 28th. From this slide, we can see that the sputum culture revealed Candida albicans on the February 13th, and carbapenem-resistant Klebsiella pneumonia on the February the 17th, and Acinetobacter pneumoniae on February the 25th. So we escalated antibiotic strategy, which combined different antibiotics and antifungals according to the cultural results. This slide showed the input and output and the urine between the day 13 to day 36. We also applied CRT to keep homeostasis and fluid balance. This chart shows the dynamic changes of laboratory findings between the day 13 to day 36. We re-examined the chest CT on February the 16th and February the 22nd. It didn't show any improvement on the images. As the sepsis were progressing, we worried about the non-infection and the castor-related bloodstream infection. The patient had been oral trachea intubated for 23 days. So he underwent tracheotomy on March the 4th. Because of the need for anticoagulation during ECMO and coagulopathy, the blood oozed around the tracheotomy wound. We frequently changed the wound in dressing and sutured the wound to stop the bleeding. The oral ulcers were also seen because of long duration of oral trachea intubation. We also restored central venous catheter and used the PICC instead. We used the fiber bronchoscope to suction airway secretion and keep the airway open. The bacteria culture from the secretion of lower respiratory tract was done daily. Repeated 2019 coronavirus nucleic acid tests were negative. We selected antibiotics according to the results of the bacterial culture. And the indicators of infection gradually improved. You can see from the chart. We reduced the dosage of sedative and analgesics, try to keep the patient with light sedation. As the respiratory function improved, the patient successfully weaned from the mechanical ventilation on March 13th and switched to high-flow nasal cannula the patient would keep awake during ECMO. And the patient was successfully weaned from ECMO on March the 16th. The dynamic lab results showed improvement from this drug. And the CT scan between the March 6th and March 30 showed multiple ground glass shadow in both lungs are observed. Early rehabilitation may help the patient to improve the quality of life. Until now, the patient is still hospitalized and getting better day by day. Our experience and apply effective respiratory support promptly include the nasal catheter, oxygen mask, high flow nasal cannula, mechanical ventilation, and even ECMO. Non-invasive ventilation is effective, but do not delay invasive ventilation. When the patient is still breathing with difficulty and has high respiratory rate during using the high flow nasal cannula or BiPAP, recovery of respiratory function may lead a long period. We should use lung protective ventilatory strategies from position ventilation for severe areas. Fiber bronchoscope is helpful to keep the lung open and to avoid airway obstruction. We should carefully assess the indication for initiating and weaning the ECMO. Sepsis is common among critically ill COVID-19 patients. Prevention of nosocomial infection is very important. Closely hemodynamic monitoring is essential. Fluid overload is harmful to critically ill patients. Renal replacement therapy and blood purification treatment to keep fluid balance, to keep the electrolyte balance and clear inflammatory cytokines. Early rehabilitation is helpful to prevent ICU-acquired weakness and to improve the quality of life. That's all. Thank you for listening.
ECMO. How many patients you ended up using ECMO?
In our hospital,
yes,
the total number of the patients were applied ECMO is 5. Yeah.
Are you in a position to say that? I know it could be difficult, but that was it beneficial, or was it in those patients the outcome was better?
Sorry. We found in the lung region from we recover for a long time. So the ECMO on these patients will last for as long as 50 days. So only the invasive ventilation is not enough. And the patient for lung ventilation will result in the ventilatory induced lung injury. We also found the bad tremor in this patient. Okay. So I think ECMO is the rescue therapy for these severe ALS patients.
I'm Jian Guoshi from the Department of GI Surgery, the Central Hospital of Wuhan. And you can call me Dr. Shi. On behalf of my boss, Professor Han-Sung Du, I will address some experience in the diagnosis and treatment of emergency patients of GI surgery during the prevention and control of COVID-19. COVID-19, that is the official name for the virus that has now affected the whole world. According to the WHO notification of the outbreak as of 5 April, as shown on this slide, the United States has the highest number of cases, yet the country with the highest number of deaths is Italy. Both number of confirmed cases and deaths, Britain ranks high over the world. The COVID-19 outbreak is still full of a lot of uncertainty in the world. In China now, most of the confirmed new cases are imported. This is easier to control than earlier outbreak in Wuhan. I want to talk about something else here. I've been working in the hospital or staying indoors after work in Wuhan through the entire epidemic. During this time, everyone in China has been doing something called social distancing. People in China have totally changed their lives, changed their mindset, changed their living habits in order to prevent the spread of this virus. It's an incredible thing to witness even as a Chinese. Social distancing and the face masks for all. The whole nation has been waiting. Amazing, absolutely amazing. Okay, this is a mobile cabin hospital converted from Wuhan Stadium. Our country has almost built 13 cabin hospitals and 2 new hospitals. 火神山 Hospital and 雷神山 Hospital. Suspected cases with mild syndrome, symptoms were transported from the community to the cabin hospital for observation and basic treatment. Only confirmed cases were admitted to the Huosenshan Hospital and the Leishanshan Hospital and the other designated hospitals. According to BBC News, London's patients in need of intensive care but with the best chance of survival will be taken to the Nightingale Hospital, an intensive care hospital with 4,000 beds. The hospital will be the biggest intensive care unit in the world. There will be one in the Manchester. Although I'm a gastrointestinal surgeon, I still need to be familiar with the COVID-19 risk policies, diagnosis and treatment programs, and the prevention and control measures of nosocomial infection. The government has organized the experts to develop kinds of treatment plans for COVID-19, which are constantly updated. Some experts have formulated certain consensus or suggestions based on the characteristics of their own specialties. COVID-19 attacks alveolar epithelial cells through SC2 receptor expressed in alveolar epithelial cells and initiates an inflammatory response that leads to the development and progression of interstitial pneumonia. COVID-19 can also bind to SC2 receptor expressed in mucosal epithelial cells of the digestive tract and affect the function of digestive system. Therefore, patients with the novel coronavirus pneumonia may have gastrointestinal symptoms, which are mainly manifested as poor appetite, nausea, vomit, abdominal pain, and diarrhea. Some patients even have gastrointestinal symptoms as the main or the first manifestation. The following study shows that approximately 48% of COVID-19 patients have digestive symptoms. Some of these patients require emergency treatment for the gastrointestinal surgery. We will face special challenges in special times. The gastrointestinal surgery is an important branch of the general surgery with many diseases and complicated conditions. The common emergency diseases of GI surgery, including acute appendicitis, gastrointestinal obstruction caused by a tumor or non-tumor, gastrointestinal perforation, persistent gastrointestinal hemorrhage, and apparent abdominal pain with unknown cause. The surgical treatment of gastrointestinal surgery, the recovery time of post-operative lung function was prolonged due to general anesthesia, ventilator-assisted ventilation, and post-operative pain on the bed, especially in the case of systemic protection. Our surgical field of vision is not very clear, and the operation will be slow, so the operating time is longer than usual. Most of our patients had abdominal infections, which, combined with the impact of surgery, made the prognosis of NCP patients worse. We still need to differentiate with the acute abnormality of internal medicine, obstetric and gynecology, and consult if necessary. This picture shows the scene of operation for a patient with chronic tumor obstruction. We conducted a right hemicolectomy plus ileostomy. When we conduct operation, some suggestions may help. Comprehensive equal gentle operation to avoid iatrogenic injury. So far as possible to shorten the operating time to reduce the risk of exposure. It's recommended to avoid the use of electric knife during the operation for patients with COVID-19. That could reduce the generation of aerosol and reduce the risk of infection of medical staff. Because three-level protective measures can reduce the visual, auditory, and tactile functions of medical staff and affect the operation. It is recommended to use iodine or hand sanitizer or antifogging paper towel and other hydrophobic liquid to smear the goggles or wear a comprehensive respiratory protective device or a positive pressure height cover to maintain a clear intraoperative vision. We often sweat when we operate in a level 3 protective condition. And sometimes it's like being caught in the rain. So be careful not to get a cold after the operation. We operated 5 emergency, maybe 6 emergency surgery during the outbreak. A laparoscopic appendectomy and an open, 2 gastric perforation repair operations, incision and drainage of large perianal abscesses, a red hemicolectomy plus ileostomy. That's all, and hopefully the world will soon get better. Thanks.
Any patient, cancer patient who needed an operation, did they go to COVID negative hospital and not to your hospital?
其他病人，比如说癌症病人，医院继续治疗。
No, they were transferred to the other hospital.
COVID negative hospitals. Okay.
Yeah, COVID negative.
And before the operation, when a patient is confirmed COVID, he or she will be transmitted to the designated hospital. But some case we can't confirm the case before operation. So we also operate some patient after surgery confirmed COVID.
Okay. So
yes.
Thank you, Peter. You might have to translate this for our colleagues in Wuhan.
Yes.
Can you hear me, Peter?
Yes.
Thank you. So from the 1st of April, China is reporting the data as symptomatic and asymptomatic positive COVID cases.
Yeah.
To my surprise, it was published on BMJ on the 2nd of April. They're currently saying that nearly 80% of the cases which are confirmed COVID positive by laboratory test do not have symptoms. So they are asymptomatic. Now, which changes everything with our COVID-free hospitals, emergency surgeries, planned surgeries, and other plans that we are doing.
Yes.
My concern is that we know that nosocomial transmission is very well explained, and the vulnerable post-operative and other immune suppressed patients who are in these COVID-free hospitals might be exposed to a virus and cause severe illness.
Yes.
So inadvertently, without our knowledge, this is new data coming out from China, which will have a high impact on other countries, because most of our plans are around COVID versus non-COVID zones, essentially.
Yes.
So we're trying to separate in a big way and see whether we can keep the patients who are not COVID positive. But my concern from new data emerging that nearly 80% can be asymptomatic and transmitting, which changes the whole concept of how we are managing globally of having COVID positive wards or hospitals and COVID negative ones.
Yes. 这个问题比较，他说了很多，实际上这什么意思呢？也就是说呢，
a symptom people who are carrier for the virus. So right now in our hospital, we still took the the third level of protection in our outpatient and also the inpatient department. And for the other population in Wuhan, so the government also takes some strategy for detection to detecting the nucleic acid for the people who go out for work, for school, or for outpatient So, and also the test of the nucleic acid is much faster than before. So it will be much easier for us to test those people who are carrier for the virus, because we also know that it is very important if those people who are carrier, they just go outside and eating and also gathering with each other. So it's quite dangerous for other people and also dangerous for the all the medical staff and hospital. So in our city, we have already taken the strategy to test in the people who are out in the public. So they have the possibility to go to the public and go to work or go to the hospital. So they are forbidden. They are mandatory to take the test if they want to go for
where
work.
do they get these tests? How do they get
in
these?
Hospital, in every hospital.
So the people have been asked to go to the hospital to get tested.
Yes, if the people want to go back for work or for school.
Okay.
Yes, they have to show the certificate, show the results for nucleic acid. If it is negative, it is allowed to go for work. If it is positive, it has to be quarantined.
Thank you. That's very useful because